Okay, Assalamualaikum and very good evening to all of you. Thank you very much for joining us at MedTweetMy professional webinar session. First of all, I'd like to thank both of the speakers, Dr. Mashood and Dr. Shanmugam from National Heart Institute, or known as IJN, for agreeing to give a talk tonight so that actually we can learn about the innovative strategies for cardiac assessment. As what we all know, there's a lot of modalities that we can apply in a way to make sure that we give the best cardiac assessment to the patient, and we know the risk. The cardiac assessment is ideal for surgical interventions or actually prior to coronary angiogram or angioplasty. So some centers might have a lot of imaging modalities like in IJN and other cardiac center, and some centers only have a few modalities that they have, mainly stress tests. So today we will discuss each of the modalities that have, especially in Malaysia, and how we actually going to apply it to our daily practice. Doesn't mean that you don't have this advanced technology imaging that you cannot do a cardiac assessment for your patient. So both are speakers from IJN. First of all, we will start with Dr. Mashood. He's a clinical fellow in cardiology and internal medicine physician from National Heart Institute. He just entered IJN recently. So the topic that he will discuss is about modalities for cardiac assessment. Okay, so without further ado, I would like to invite Dr. Mashood to deliver his lecture.
All right, thank you very much, Dr. Iskandar, for the kind introduction. Hi, and good day, everyone. I'm Mashood, cardio fellow and internal med physician from Institut Jantung Negara. First and foremost, I'd like to give my thanks to MedTweetMy for the invitation, allowing me to share in this platform to all the audience tonight. So I've been given a task to talk about modalities in cardiac assessment. I think last year we had discussed in this similar platform as well. We talked about stress tests, the indication, and how to interpret. So there's now a slight twist in the topic, but I think it's good for all of us, especially those in a general medical and a primary care setting. So let me share my slide. Right. Okay, so the topic today is modalities and cardiac assessment. So let's start. So let me share with you a case scenario. Now we have this young gentleman, is a 25-year-old, is a national badminton player, and he eats healthy food. And at the same time, he doesn't smoke and he doesn't vape. But one thing is of concern, he is really much concerned of his heart condition. Especially because of the recent case, a badminton player from a neighboring country who died because of sudden cardiac arrest during tournament. I think that player was quite young as well, about 20 years old. So he comes to us to seek for medical advice. So let's say we are the doctor who see our athlete here. What and which cardiac test that we would offer to our athlete? So are we talking about treadmill test? We want to offer stress echocardiogram. It can be dobutamine stress echo or treadmill stress echocardiogram. Or do we want to talk about CT coronary artery? Or we want to offer perfusion imaging scans such as cardiac MRI or nuclear scans such as PET or PET scan? Or we want to offer our athlete here an invasive coronary angiogram in which we can do both diagnostic and therapeutic measures. Or we want to go for all of the above so that we get a concrete answer and definite answer for our athlete here. So you keep your answer to yourself first. Let me share this slide. Let us have a bit of recap about all of this cardiac assessment. So as a start, stress test is not a diagnostic test. It's actually a screening test, but it still has its own popularity and high demand. Because apart from screening, stress tests, we can assess exercise functional capacity, we can assess symptoms and assess the blood pressure and heart rate response during treadmill, and we can also do a prognostic test in terms of cardiovascular event in 5 to 10 years time. We can calculate the Duke treadmill score. whereby for the rest of the tests stated here are diagnostic tests. But CTCA, it measures anatomical assessment in the sense that we look at the coronary arteries and we see, are we dealing with non-obstructive or obstructive CAD, whereby the rest of the tests are functional assessment. But for invasive coronary angiogram per se, we can assess both anatomical and functional during angiogram. Apart from looking at the coronary arteries angiographically, we can do some physiological tests such as QFR and FFR, right? So this is the ischemic cascade. It's good to know that we start our ischemia process starts with metabolic changes, and then followed by perfusion changes, and then changes happen at the cellular and tissue level, and only after that we can see diastolic dysfunction and systolic dysfunction, and afterwards we can see STT changes from the ECG, and only after that we can see ischemic symptom here at this level, in which patient will complain to us, for example, angina or dyspnea, and eventually at the end of the ischemic cascade is the myocardial necrosis. So it's very important to know about this slide, because each of our cardiac tests, it detects ischemia at different point, at different stage. So for example, MPI is myocardial perfusion imaging. This is where our cardiac MRI, our SPECT and PET scan detect ischemia. So they detect ischemia at the early stage of the ischemic stage, right? Whereby for stress echocardiogram, they detect ischemia at the mid stage, and ECG, or probably talking about treadmill tests or cardiac enzymes, they detect ischemia at the end of the ischemic cascade. This is a very good figure from WHO, which is stated in the latest ESC guidelines as well. So WHO has divided the region across the world according to cardiovascular risk. So we can see here, the one red in color means very high risk of developing cardiovascular event. The region shaded in orange color is high risk, whereby those region shaded in yellow color is moderate risk of developing cardiovascular event, followed by low risk shaded by the green color. So if we zoom in, so Malaysia actually belongs to a moderate risk of developing cardiovascular event, which is quite high for a very small country. So it's a very good timing to have the CME as well, because I can share the latest ESC guidelines on management of chronic coronary syndromes. So ESC advocate for asymptomatic healthy individual, like our athlete just now, for us to use this SCORE-2 or SCORE-OP model to detect individual at high risk of developing cardiovascular event and to guide us for our treatment decision. So what is this SCORE-2 model? So this is an example of the SCORE-2 model. So actually there has different model, depends on the cardiovascular risk across the region. So I share in the slide is the moderate cardiovascular risk, because our country belongs to the moderate cardiovascular risk. So let's see what's the parameter needed for our SCORE-2 model. So we need the blood pressure here, and we need the age, all right? And at the same time, we need gender and smoking status and the non-HDL cholesterol as well. And from there, we re-stratify our patients. And then we follow the algorithm. Either we need to offer our individual certain tests, or we can defer tests, etc. All right. So for example, okay, so we can see from here, actually our athlete falls, the age is 25 years old. It's not even in the SCORE-2 calculator. Okay, so means it's either low risk or we are dealing with very low risk. All right. So what if in the case of an elderly lady, which is very cheerful, our auntie here, our grandma here, she's 75-year-old, but unfortunately she has high blood pressure, diabetes mellitus, hypertension, and dyslipidemia. And at the same time, she came to us with symptoms of angina, but upon assessment, the angina is quite stable and she is safe to be discharged. It's just that we are contemplating, we are puzzled. Are we dealing with chest pain of cardiac event, cardiac related, or non-cardiac related kind of chest pain? All right. So for this case, ESC also share in their guidelines. This is the latest one as well, 2024. For symptomatic patients that we suspect CCS or CAD, we can use this RFCL model, risk factor weighted clinical likelihood model. So it's different. For example, our athlete just now is a asymptomatic healthy individual. So for that kind of individual, we use a score 2 model. For those who have symptoms, and we use this risk factor weighted clinical likelihood model, or in short, RFCL model. So in ESC 2019, actually the model that ESC proposed was the pretest probability model. So now they come with a new model, which is this RFCL. So how to use this RFCL model? So first of all, we need symptoms. That's why this this model is for those symptomatic patients. So if let's say patient has dyspnea, automatically they score 2 points. And if let's say our patient complain of angina, right? So angina can score from 0 to 3 points, depends on the nature of the chest pain. And then the number of risk factors from 0 to 5, like in Our Lady here, at least we have 3, dyslipidemia, hypertension, and diabetes. But of course, we need to ask further on family history. And then number 3 is the modifier, later I will share. So, okay, let's say Our Lady here complained of angina, and she scored 1 point, in the sense that it's aggravated by physical and emotional stress. The rest are atypical, and she has no dyspnea. But at the same time, she has family history. So in terms of risk factor, she scored 4. So an Our Lady is 75-year-old. How to use this calculator? So symptom score, she scored 1 point, right? And she's woman. And in terms of number of risk factor, she has 4, and she's 75-year-old. So she's at low risk, actually, of developing cardiovascular event. But keep in mind, this RFCL model, they have modifier. You see number 2 here. So if let's say any of the modifier positive, it can either increase the risk from low to either moderate or even high, or from low to very low. So we need to do an ECG to Our Lady here and check whether are we dealing with any STT or Q wave changes. Is there any evidence of ventricular arrhythmia? Or from the echo, any evidence of left ventricular dysfunction? Or she has concomitant peripheral artery disease. All these are modifier. And number 3 is another modifier, which is a calcium score. So if the calcium score, you see, let's say this lady falls under moderate risk, right? Sorry, low risk. And for example, her calcium score is more than 400. So from low risk, she can become very high risk. She can become high risk, sorry. So let's say we are talking about calcium score of more than 1,000, she can become very high risk. And that's how we use the modifier. Okay. And then after we have stratified our patients, either by using the SCORE2 model or the RFCL model, then we follow this algorithm. If let's say like our athlete just now, he's considered a very low risk, so it is safe actually to defer further testing. So we can say to our athlete, actually pretty much unlikely you are not dealing with any cardiac event, but you can continue to do your annual medical checkup. All right. But for instance, our elderly lady here, after we put in all the modifier, let's say she falls under high risk. So you can see here, if high risk, we can go with functional imaging. So functional imaging can either be PET or SPECT scan, can be a cardiac MRI, can be a stress echo as well. Okay, all right. So this is just another algorithm. Let's say the patient falls under low risk, in which CTCA is what advocated by ESC as per guideline. If let's say the CTCA is deemed inconclusive, okay, we can go with functional imaging test, and vice versa. Okay, this is as per what stated in the ESC 2024. For those with low to moderate risk, it's a class 1 evidence to go for CTCA. All right. But for those with moderate to high risk, after we have certified the patient, stress echo, it's either treadmill stress or the vitamin stress, is a class 1 as well. And then for moderate to high risk, cardiac MRI, SPECT scan, and PET scan is a class 1 for to offer for the patients as well. Okay, so this is another image to show the coronary arteries. So our coronary arteries, they are divided into macrovascular and microvascular circulations. So the one that we can see on scan or in angiogram is epicardial arteries and small arteries. For example, left anterior descending, you can see the epicardial part and the small arteries part in the angiogram. And their size range from 1 to 6 mm. Whereby for the microcirculation like arterioles and capillaries, that one can't be seen angiographically because the size are very small, less than 300 to maximum 400 micrometer. Okay. So I think that's about it for the score. So now I just want everyone to at least understand that we have these two scores, score 2 model and RFCL model that we can apply to our patients. For those asymptomatic or healthy individuals that probably we see in our clinic, we can use this score 2 model to certify. And for those who have symptoms, we can use this RFCL model. And you can find that figure in the ESC Guidelines 2024 in their website, right? So now we are going to talk briefly about each of the imaging tests. And I'm not going to go into details because if we want to go into details in each of the tests, it warrants a separate lecture and it better be best explained by the radiologist or probably the nuclear medicine specialist. All right, so the first cardiac test is the SPECT scan. That's a short form. The full name is single photon emission computed tomography. So why single photon? Later I explain. So when we want to talk about SPECT and PET scans, I kind of want to talk about a little bit on PET scan as well, because these are the two most common imaging modalities in nuclear medicine. So last time I used to thought that all scans, all imaging belongs under radiology, but it's actually not. Some of it belongs under nuclear medicines. So which are the tests that belongs to the nuclear medicine? So the scan that use radioactive traces, those belong to nuclear medicine. So these radioactive traces, although it sounds radioactive, they have underwent tests and approval. So they are actually called radiopharmaceutical, means they are safe and they are effective for clinical use. All right, so these radioactive traces, they are molecules and they are bonded tightly to radioactive atoms. And most of the tests, these radioactive traces, they are administered intravenously. Although some diagnostic tests that they might give it orally or via inhalation, right? So this is just another figure for me to explain. I mean, what's the difference between SPECT and PET scan? So for SPECT scan, the general idea is that they use different type of radioactive traces. So the radioactive traces used by SPECT scan, you see on the right side, we inject them intravenously and they get circulated in the bloods and they diffuse into the organs both intracellularly and extracellularly, and they decay in our body and they will release one gamma ray. So this one gamma ray is the one detected by the SPECT camera and produce image. So remember SPECT, the decay product is one gamma ray. However, for PET scan, once we inject the radioactive traces intravenously, diffuse to the organs, and it will decay as well, depends on the half-life. But this time around, the PET radioactive traces, they will decay into 2 gamma rays. So these 2 gamma rays will get detected by the PET camera and produce image. Hence, why this explains why PET has better image quality and accuracy, because they have more decay products. So their quality of image is better. I mean, that's the general idea of it. So these are the type of radioactive traces for both SPECT scan and PET scan. So for SPECT scan, we have the technetium tetrophosphine or sestamine B. And whereas for PET scan, we have this ammonia, rubidium, the FDG, right? So this is an example of SPECT scan machine. You can see the HD detector and the collimators are the 2 cameras that will rotate during the SPECT procedure for them to capture image. And then this is how they do a perfusion SPECT scan. So they will start with stress stage first, inject the technetium 99, the radioactive traces. And for the stressor, usually we use a pharmacological agents such as the pyridamol, adenosine, and regadenoson, all are vasodilators, and we take the image after the stress. And after that, the resting stage, we do the same thing, but this time around, not using any pharmacological agents, and we take image during rest. And then we evaluate and interpret the findings. These are the example of the images from SPECT scan. So we have a static perfusion image at different axes, short axis you can see up there, and vertical and horizontal long axis as well. And then on the right side here is attenuation correction. It's a hybrid of SPECT and CT scan. Nowadays, we use hybrid scan for better image quality and image accuracy, because by using hybrid scan, both SPECT and CT, they can form an attenuation correction, which means they can eliminate any soft tissue artifact and produce better image. And then there's an image of 17 segments of the heart as well to measure defect size. And sometimes in SPECT scan, they can form this ECG gating image to check for LV function and desynchrony. This is an example for the SPECT scan with CT hybrid. The main reason is for attenuation correction, so to remove soft tissue artifact from SPECT image to get a better image quality. So that is at least comparable with PET scan. All right. So these are another example of SPECT images, static perfusion image. So you can see the top one. This is short axis from apical to basal. And the upper part here is the stress stage, and the lower part is the resting stage. Then they have this vertical long axis as well. Again, the upper part is the stress stage, and the lower part is the resting stage. And this is for the horizontal long axis. So why this different view? Because they can assess different wall motion. You can see from the short axis, they can assess septal, anterior, lateral, and inferior. Whereas in a vertical long axis, they can assess anterior and inferior wall. And in horizontal long axis, they can assess septal and lateral wall. Okay, this is a general idea how we interpret SPECT scan. Of course, I'm not going to go into details. I just go through it briefly, right? So the upper part here is the normal image of SPECT. So normal image means normal uptake, which is equivalent to normal myocardium, all right? So you can see in the short axis, this is the image example of a normal uptake. For horizontal long axis and vertical long axis, this is an example of normal uptake as well. For if it's abnormal, there will be zone or area of reduced uptake, as you can see here. So there's reduced uptake over the anterior wall, and here you can see there is a reduced uptake over the apical wall, as well as this vertical long axis as well. So reduced uptake means unhealthy myocardium, so the blood flow unable to catch as much as radioactive stresses as per normal myocardium. So let's say we are dealing with this kind of image. For example, at resting, you can see normal uptake, but during stress stage, reduced uptake. So this is likely indicating ischemia, all right? Okay, I just shared this for, I think, for learning purpose, because these 17 segments of heart model based on AHA, you can see they divide the heart into 17 segments, in which 7 segments, this dark purple, belongs to LAD. And then for left circumflex and RCA, each of them has 5 segments each, all right? And this outer part is what we call as the basal. The mid part is mid, and the center part is apical. So for example, if let's say this area is what we call as apical anterior. So you know, this side is septal. The mnemonic is SALI, septal, anterior, lateral, and inferior. So here, this part is anterior. So we're talking about area 13. We are talking about apical anterior. Let's say if we're talking about area number 3, we're talking about basal inferoseptal. Why inferoseptal? Because it's in between area of septal and inferior. Okay, that's a general example of it. So this is just a brief summary on how to interpret all these SPECT images again. if both at resting and stress stage, we are dealing with normal uptake, so it means a normal myocardium. If in resting stage, normal uptake, but at stress stage, it shows reduced uptake, we are dealing with some ischemia. If both at resting and stress stage, we are dealing with reduced uptake, likely we are dealing with scar or hibernating myocardium. Scar means infarcted area, okay? So in certain, in certain circumstances, we can see during stress stage, it induced cavity dilatation, in which we call as transient ischemic dilatation. So this indicates severe or extensive CAD. Either we are dealing with multivessel or left main disease, right? So for next, we are going to talk about PET scan. So PET scan is a positron emission tomography, right? So why positron? Again, it got to do with the radioactive traces agent as well. So the main difference between SPECT and PET scan is the types of radioactive traces that they use. The positron is a particle used in the radioactive traces. So, general idea is that the radioactive traces used by the PET scan, they will produce two types of gamma rays. And once the radioactive traces in our bloodstream in the body, they will react with electrons and they will annihilate each other and produce these two photons that will get detected by the PET scan. So this is just another figure to show a PET scan. We have a molecules, and then it react with electrons in the body, and it decay into two gamma ray, and both gamma rays get detected by the PET scan. So this is an example of PET scan. Of course, different brand has slightly different structure. Okay, the thing about PET scan, why it's gold standard, is that apart from the qualitative assessment, they have quantitative assessment, which is not available in SPECT scan nowadays. So what are the quantitative assessment in PET scan? They can measure myocardial blood flow according to the segments you see. So, and the myocardial blood flow for each of the territory vessels is at rest and at stress. And then we have a MBFR, myocardial blood flow reserve, which is the ratio between these two. So the general idea is that anything more than 2 is considered normal, all right? But of course, if you want to go into details, certain studies have shown that, as you age, the normal value of MBFR reduces. So it ranges from 2.1 to 2.8, all right? So like, for instance, this LED more than 2, CERC more than 2, and RCA more than 2 as well. And the average global means average for all of the territories more than 2. So we can safely say that this is a normal MBFR for all the 3 vessels. So MBFR expresses the ratio of a hyperemic flow to both myocardial blood flow at rest and at stress to assess the vasomotor dysfunction. So this is an example of PET image. You can see on the left side, it's a qualitative assessment, all right? Okay, in a while, sorry, my laptop is out of battery. Okay,
never mind. While Faiz is trying to settling his laptop, so I'm sure that most of you already have some ideas. Actually, Faiz have explained in quite detail about the technetium scan, also CT scan. Yeah? So as the graph that he showed just now actually is quite interesting, where actually you have to understand that you doesn't need to actually wait until there's this ECG changes that you need to do this cardiac imaging or cardiac evaluation. Okay, so TET scan can be more sensitive compared to echo. Echo is better than ECG. Okay, Faiz, okay?
Okay, okay. So
proceed.
okay, okay. So this is an example of one of the patient PET scan images. So on the left side is a qualitative static perfusion image, and on the right side is the quantitative assessment. So we'll go on the left side first. So you see on the left side, we can see the short axis image from apex to base, both at stress and at rest. So, I mean, the general idea, of course, we are not radiologists and we are not a nuclear medicine specialist. But if we want to learn how to interpret at least, we can compare, you see, both resting and stress stage. Is there any discrepancy? And are we seeing all normal uptake? Is there any reduced uptake that we can appreciate? From my assessment, you can see here, it seems like normal uptake from apical here, both resting and stress stage up until this level actually. So the short axis, it looks normal. Then we go to the horizontal long axis, we compare both rest and stress, and it actually looks normal uptake to me as well, all of the images. And then we go with the vertical long axis. This is to from septal to lateral wall, and it actually looks normal uptake. But then in the PET scan, there's an additional quantitative assessment, like I say. So you can see the MBFR for LAD is way beyond normal, 3.4, CIRC 3.0, RCA 3.6, and the average is 3.3. So we can safely say that this is a normal perfusion study. Okay, so moving on to the next image. Okay, this is an PET scan images for 80-year-old man with a known CTO of the RCA, means a total 100% block of the right coronary arteries. But this time around, he's presented with worsening dyspnea. So we did this PET scan. Okay, put aside the MBFR on the right side, we see the image on the left side first. So we see on the short axis here, right? The apical at rest and at stress, it looks the same until we go into this basal segment. You see, this is at rest and this is at stress. You can see reduced uptake at the inferoseptal segment if you compare, right? There's a reduced at the inferoseptal segment, whereby when we go through the vertical and horizontal log axis, for me, it looks normal, all right? And then what about the MBFR? So the LED MBFR ratio is 2.27, acceptable. For CIRC, left circumflex is actually borderline 1.99. We accept 2 because he's 80-year-old. Whereby for RCA, it's reduced 1.83. But in average, globally, 2.09 is normal. So what's the finding actually for this PET scan? It's actually a reversible perfusion defect at the inferior and inferoseptal wall. We are talking about this segment. And then the MBFR is globally normal. However, the MBFR for the inferior wall means RCA is abnormal. So the conclusion is consistent with known CTO RCA, but the LAD and left circumflex is a non-flow limiting disease, which means we can intervene or try to reperfuse the RCA, the CTO. Okay? Okay, that's about it for PET scan. Now we're moving on to cardiac MRI. So cardiac MRI is another imaging test. It doesn't use radioactive traces, but instead it uses high magnetic field and radio wave to produce image. The thing about cardiac MRIs, I mean, it's very useful. It has variety of protocol. So you can assess cardiomyopathy, you can assess etiology of heart failure, you can assess masses and inherited disease, and most importantly, it can assess perfusion defect and viability as well, same like SPECT scan and PET scan. Example of cardiac MRI machine, again, different brand, slightly have different structure. This is an example of cardiac MRI images. And this you can see the moving image and dilated LV and RV as well with good ejection fraction. And then this is the type of protocol available for cardiac MRI, which is you can see we can see late gadolinium enhancement for cardiac MRI for different interpretation correlate to different disease. For example, diffuse LGE correlates with amyloidosis. If you're talking about subepicardial late gadolinium enhancement, probably sarcoidosis, right? And then they have this additional sequence such as T1 mapping, T2 mapping, or T2 star mapping. And at the same time, they again can assess stress perfusion and viability as well. I mean, talking about variety of protocol in cardiac MRI. And then moving on to the next imaging test, CACS is coronary artery calcium scoring and CT coronary angiogram. So calcium scoring, you can see 4 images. These are 4 different images for 4 different patients. This one is a calcium score of 0, calcium score 250. You can see mild plaque disease there. And then calcium score of 1200, you can see extensive plaque disease all over. So for calcium scoring, they use a Gaston scale. Generally, any score below than 400 is correlates to mild to moderate CAD. By more than 400 indicates likely we are dealing with severe CAD. If a score more than 1000, 25% chance of heart attack within a year. But keep in mind, again, calcium scoring is similar like treadmill test or EST. It's not a diagnostic test. And it has less accuracy as people age, because, I mean, elder people, you know, the vessels are calcified, so the reading is a bit off. All right. And then this is an example of CT coronary angiogram. We will get this sort of like 3D image of the heart and the coronary arteries. And from there, the radiologist will assess whether are we dealing with obstructive or non-obstructive CAD. And the score that they use is the SCAT-RAT score. The general idea is anything score 4 and above, 4 or 5, means that we are dealing with severe stenosis. And then we have a stress echocardiogram, which can be exercise or dobutamine stress echo. So exercise stress echo means we do a treadmill test and we do an echocardiogram, both at rest and after stress, and assess the hypokinetic and the ejection fraction. Whereby in the case of the dobutamine stress echo, we stress the patient as well, but usually in elderly patients who are not fit for treadmill test. So we use dobutamine as a pharmacological stressor, but we do the echo image before, during, and after as well. So apart from assessing the heart, both the EF and the RWMA and the hypokinetic area, stress echo also can differentiate between true severe AS and pseudo severe AS in the case of low flow, low gradient AS. So this is the dobutamine protocol for DSE. So at rest, we take an echo image, and then we start the IVI dobutamine infusion with 5 mic per kilo per minute. Then we increase to 10, 15, 20, and maximum of 40 until we achieve target heart rate. And each of the phase, we assess the echo as well. And we do another echo at the recovery. Okay. And let's say the heart rate is not achieved, we can use IV atropine as well during the SE. So this is the example image of the SE. Okay, you can see this image is at rest. You can see normal contractility of a septal and posterior, both pointing inwards. But in the case of stress, there's slight hypokinesia over the septal area that we can assess here. This is an example, right? Then moving on to invasive coronary angiogram. So these are an example of coronary angiogram image. Okay, basically coronary angiogram is a diagnostic test as well, but it is considered invasive because we need to puncture patient, we need to put in wire all the way to the heart and things like that. So there are risks, although the risks are very minimal, we still need to explain to patients, and the risk can sometimes be fatal because we're talking about heart attack, we are talking about cardiac arrest, we are talking about stroke during angiogram. And during angiogram, we can do some physiological assessment like QFR and FFR to check the blood flow, the patency of blood flow of each of the coronary arteries. So QFR 0.72, this is significant, which means we need to intervene either by putting balloon or stent. Okay, the same goes with FFR, the cutoff value is 0.8. And this is the technical comparison for each of the tests. So for SPECT scan, generally, it's the most common perfusion scan used because of its wide availability. But again, if you're talking about image quality, it's slightly lower compared to PET scan. Talking about PET scan is the gold standard, but again, it's costly and the availability is limited. And for MRI, the disadvantage, it can't assess the coronary stenosis and there are lack of quantification assessment. Same goes with CT coronary arteries. There's no quantification assessment, and there's involvement of a contrast, which is not feasible for any of our CKD patients. In the case of echocardiogram, it's available bedside. That's the advantage, but it's again operator dependent, and its advantages, there are no quantitative assessment like PET scan. And for coronary angiogram, it's a limited use because of, again, the small risk that I'm talking about just now. But the advantage is we can do both diagnostic and therapeutic under the same setting. So these are the specificity and sensitivity of each of the tests. Put aside the treadmill test, the rest of the test actually has at least specificity and sensitivity of 80%. So if you ask me, what is the best test for the patient? First, we need to re-stratify again, and then we decide. And let's say patient falls in between moderate to high risk like that. It depends on the availability in our center. And we need to talk about cost as well. If everything is available and cost is not an issue, again, the gold standard is PET scan. So this is, as mentioned in ESC, exercise ECG is recommended for assessment of exercise tolerance and to evaluate event risk. It is not a diagnostic test. And this is a definition of high risk for each of our cardiac assessment tests. All right. So with that, thank you very much. Sorry for the technical problem just now. So I hope with this, at least everyone knows how to stratify our patients by using either SCORE2 model and the RSL model. And at least we know a little bit on each of the tests so that it can help us to choose for the benefit for our patient. So with that, I pass the floor to Dr. Iskandar and our second speaker, Dr. Sharmila.
Okay, thank you very much, Dr. Faiz, Mashood. Such a very wonderful lecture that you give just now. So I think most of us understand at least the basics about all these cardiac modalities. You can see stress test is still good to assess cardiac assessment, to do cardiac assessment, but you can see the sensitivity become from 70 to 85% if you do the stress echocardiography. So by just additional of echocardiography, the sensitivity become better. So that's why actually in IGN I like to do this stress echo, because the sensitivity is because another thing is because it's widely available in IGN and it can be done very fast. So next we go to the second speaker. This one will be presented by Dr. Sharmila Shanmugam. She's a clinical fellow in cardiology and also interim as a physician from the National Heart Institute. So the aim for the talk by Dr. Sharmila is to give you more understanding in the case-to-case approach, so that you know not everything is angiogram. Some patients actually already have a mindset that if they have a chest pain, first of all is angiogram. So this is how actually we re-stratify the patient and choose which modalities is the best for the patient. So before we start with Dr. Sharmila, I just want to inform you, this talk we have about, we will given 2 CPD points from the MMA CPD point. And I hope that you guys can give a lot of questions at the end of the lecture so that we can have a Q&A session afterwards. And then the form for the Google form for the MMAC people were given during the Q&A session. So without further ado, I would like to invite Dr. Sharmila Shanmugam to give her lecture. Okay, you need to unmute yourself first.
Yeah. All right. Thank you very much, Dr. Iskandar and Dr. Faiz, as well as chairperson today, and MedTweet. Thank you very much for having me once again. Thanks everyone for being here Sunday night. It's my pleasure to always give you all talk to, the public, whoever that is, the professionals, healthcare professionals that are all around. Yeah. So it's quite interesting, this topic, when Dr. Iskandar approached me. So I was thinking that at your setting, how could we actually help you guys to refer as well as maybe manage on your own. Okay, let me just share my slide 1 second. Okay, is that all right, guys? Skanda?
Yeah, okay, yeah.
All right. So first of all, before I start, thank you very much for all the referrals from the GPs, clinic kesihatan, as well as the hospitals, yeah, referring to us for pre-op cardiac assessment. Quite a number of it, but excellent, because I think it's you guys that takes the history, yeah, you guys that do the clinical examination, eventually investigations, and pick it up, and at least, you know, stratify the patient when they're actually going for any form of surgery, and then wanting us to give this pre-op assessment so that we manage the patient comprehensively, and you guys can possibly reduce the risk of intraoperative and post-operative risk and mortality, cardiovascular event, as well as stroke event. So basically, as we see here, it's a very interesting and nice picture, diagram actually, from the ESC 2022 guidelines that mention that it is an interplay between the patient risk as well as the surgical risk, right? For preoperative, to actually see what is the cardiovascular complication. So here highlighted, the surgical risk can be categorized into low risk, intermediate risk, and high risk. Yeah. Later I will show you the diagram depicting which are the surgical procedures that are categorized into this low, intermediate, and high risk. At the same time, the patient's risk, if you can see here, comorbidity, very important. 3 things that I have listed is the patient's age. As they are aging, the risk is increasing. The cardiovascular risk optimization, or as simple as hypertension, dyslipidemia, chronic kidney disease, diabetes that can be managed, as well as the patients that have existing coronary artery disease. So during surgery, why is it important? It's because during tissue injury, inflammation, there will be an increase in cortisol level, inflammatory markers, and your neuroendocrine system, as well as the sympathetic system will be enhanced, right? So this eventually can lead to hemodynamically instability, right? As you can see here, patient can have diastolic and systolic dysfunction, pulmonary congestion intraoperatively, postoperatively, rhythm disorders, ventricular arrhythmias, yeah, atrial fibrillation, if it's not actually managed perioperatively. You also can see here, patients can actually have fluid or blood loss during surgery, right? And this also can cause gas exchange imbalance. Yeah, patients with valvular heart disease is another category that will increase the patient's intraoperative and post-operative cardiovascular risk. Lastly, but not least, the thrombotic and bleeding risk of the patient has to be assessed before going for surgery. Yeah. So I'm going to use the ESC guideline. The 2024 guideline is a simplified version, but 2022 is more, it's quite comprehensive. So if you can see here, I know the fonts are very small, but just to inform, why are we actually categorizing the surgical procedure risk, the type of surgery that is going to perform? Because the risk carries the 30-day mortality, yeah, in terms of cardiovascular myocardial infarction, stroke risk, as well as mortality. So the patients that are undergoing low surgical risk surgeries will be breast surgeries, dental, eye cataract surgery, yeah, minor gynecological surgery, orthopedic surgery like meniscectomy, reconstructive surgery, yeah, urological, what do you call that, as procedures as well, transurethral resection of the prostate, and minor lung resection. It carries less than 1% risk, yeah, of your 30-day mortality. Intermediate risk, you can see in this small little table here, mostly patients that will be going for whether or not they're symptomatic or asymptomatic carotid surgeries, endovascular aortic aneurysm repair, head and neck surgery. Neurological, I think is important here, and orthopedic surgery. We have a lot of referrals here for hip, spine surgeries. Renal transplant, again, urological and gynecological, a bit more major, 1 to 5%. They carry that risk. And the high risk, of course, more than 5%. These are the major intra-abdominal surgery, adrenal resection, you've got esophagectomy, cancer patients, pneumonectomy, perforated bowel, transplantation, cystectomy, and all that. So I thought, okay, what are the few steps that we can actually come up with? This is on my own. So when you're actually seeing your patients in the clinic, right? Be it any department, any sub, as well as the NS team, if they're on board today. Number one, we should think whether or not this surgery is electively planned or is it urgent surgery. If it's an urgent surgery, definitely there will be no pre-op cardiac assessment. We need to perform the surgery. It's a life-saving surgery. Go ahead and we manage and we refer to multidisciplinary teams and manage the patient concurrently. If it's not an urgent surgery, that means it's going to be an elective surgery. Step 2, try to look out for this. Any one of active or unstable cardiac conditions that occurred recently or concurrently happening, that when the pre-op assessment during the NS interview with the patient, suddenly they inform, oh, yes, I do have atypical chest pain. How long? It's been very long, 2-3 months. Things like that. So we need to ask this question. So indirectly, whether or not the patient has stable angina, unstable angina, acute heart failure, arrhythmias, valvular heart disease, or myocardial infarction, whether or not it is going to be a yes or no. If no, and either or, we need to also eventually put them into the surgical risk. It's very important. So stepwise, you can see clearly. So I've done whether it's an elective, time-sensitive surgery or urgent surgery. Step 2, any existing cardiac events. Step 3, surgical risk. Low risk, intermediate or high risk. So you can actually look back into that table I showed you earlier and categorize them. Number 4, very important, functional capacity, because the patient is in front of you. What do you mean by MET score? Less than 4, more than 4. Less than 4, functional capacity is low. That means the simplest question that we can ask when I read through this is whether they can climb 2 flights of stairs. Okay, so if they can climb 2 flights of stairs, considered above 4 already, all right, which is good. Step 5, of course, the low risk, we put them on one side, but step 5 is to further understand what extra things that we can do instead of just performing either ECG or a chest X-ray. So the intermediate risk, whether or not we want to go further to do a non-invasive stress imaging, and high risk, whether it requires invasive coronary angiogram, and also at the same time referring to the multidisciplinary team. Step 6, last but not least, what is the cardiac risk score? This is the revised cardiac risk score, will actually tell us, which I will take you through during the case studies, actually why this risk score is important. So let me take you through my first case, which is a low risk non-cardiac surgery. So Mr. Balan, 68 years old. Okay, I highlighted 68 because in the ESC guideline, they mention the important age that you have to remember is the cutoff is 65. Below 65 and above 65. So let's see, this patient, above 65 years old. He has coronary artery disease, underwent coronary angioplasty to left anterior descending when he was 48 years old, 20 years ago, right? After that, subsequently 10 years after, he went through a bypass surgery. He has 3 grafts, We call Lima LAD, that's an arterial graft. Venous graft, he had 2, which is one to the left circumflex and one to obtuse marginal. It's a branch of left circumflex, with detail, but just an idea. So number 3, so he has an established cardiovascular artery disease. Now we are looking at his cardiovascular risk factor. So diabetes mellitus, hypertension, dyslipidemia, chronic kidney disease. EGFR, okay, 50, and he's a smoker. Subsequently, 7 years after, he had a graph study. Graph study also, all 3 graphs was patent, so he was all right. Ejection fraction also was about 53%. So this is his chest radiograph. You can see the graph clips, and there is, of course, it's 2D image, but you can see there is cardiomegaly. So I'm just showing you the coronary angiogram in 2013. All right, so somewhere around here, this is what we call the left circumflex, proximal, and distal, and the obtuse marginal. So distally, complete total occlusion, yeah, 100% blockage. And this is the left anterior descending, it's diffuse. So we say from all the way from the top, all the way distally, diffuse disease, yeah. So this is why sometimes in diabetic patients, poorly controlled, they get mostly triple vessel disease, 2 vessel disease, sometimes single, but you can see mostly it's going to be a diffuse disease. This guy, unfortunately, what we call on the right side, some patients have co-dominance. That means the left system and the right system also, this blood supply is good, but he somehow, you see on the right side, we call it recessive, very small, yeah? So that's what he has, but also very diffuse disease on the right side. So at that point in 2013, they've decided for the bypass surgery. All right, so what happened after 10 years, 2013 to 2024, right? Comes in for unstable angina in February. So we thought, okay, let's do a CT scan of the graph, because sometimes as we go into the form angiogram, it's difficult for us to locate the graph. Yeah, so to minimize time and contrast, we do a CT to guide us. We can look at the graph patency. So it's mentioned here that is the, I'll show you the graph sooner. The patency of the Lima and LAD is there, but it's already degenerative. The venous graft to the obtuse marginal was patent, but the circumflex is occluded. So if you can see again, the left circumflex, now proximally earlier when I showed, if you remember, it was all right, only distally, right? So now proximal is also affected. And the left anterior descending, again, diffuse disease. The right side, the same. Okay, this one is the graph over here, right? This is Lima LAD. It's very small, degenerative. And this is the patency of the OM branch graph. So the circumflex now it's not being supplied. So that's why we decided to revascularize the circumflex with a drug-eluting stent. Yeah, very nice, as you can see here proximally. Okay, and we decided for dual antiplatelet therapy for 1 year. All right, so as you can see here, somewhere in August now, 6 months after the angioplasty to the circumflex, he comes to the clinic very well actually. NIHA class 1, no angina. Yeah, functional capacity above 4. Blood pressure not too bad, heart rate slightly. We want to achieve 70 beats per minute. We did a cardiac enzyme was 8. Pro-BNP has come down to 1006. His total cholesterol is 5.5. Good HDL, I would say, but LDL is not optimized, right? He is in the high risk category with diabetic and chronic kidney disease. Actually, we can put him as very high risk. So the LDL actually has to come down less than 1.4. And his A1C is borderline at 7.3. You can see the echocardiogram here. The ejection fraction is still very good. So what does the ESC guidelines recommend? So for patients, for the preoperative risk assessment in terms of ECG and biomarkers, actually it's mentioned here above 65 years old, symptoms or signs suggestive of coronary artery disease is recommended for your ECG, but it's actually for intermediate and high risk, 1C, and for your biomarkers, it's actually class 1B. So this guy is actually going for the cataract surgery. Yeah, actually it's a low risk for non-cardiac surgery. This is his ECG, bit of a sinus reader, yeah, but otherwise there's no much ST changes. So again, step 3, make sure that we know the patient and surgical risk. So this is the least revised cardiac risk index. Yeah, it's called actually least pre-op assessment, right? So it's been there for 20 plus years. So when I scored him, his elevated risk surgery risk was actually low. So no. His history of ischemic heart disease, yes. Congestive heart failure, no. Stroke, insulin, and creatinine, also no. So he's scored either 0 and 1 is low risk. 0 is about 4%, 1 is about 6% for 30-day risk of mortality, myocardial infarction, or arrest. So this is a short form. Revised cardiac risk index is 1, but his score risk is 10%. Score, like how beautifully this now Dr. Hafiz has mentioned, right? Score risk is very important because again, we need to look into optimization of his cardiovascular risk factors prior to surgery. So here again, low risk for the eye cataract surgery, less than 1%. Technically, at this point of time, he's well asymptomatic. We did the ECG, we did the cardiac enzyme, echo. So this is another diagram. Actually, it's quite good to have. That we'll see here. We took the history examination. So importantly, above here, it says advise on stop smoking and optimize your guideline medical therapy as recommended is also class 1. Yeah, so this is the one that I'm telling you that actually whether or not the patient is less than 65 years old with a low risk, actually you can stop there and you can proceed with the low risk non-cardiac surgery. Yeah, even patients with less than 65 years old, low or intermediate risk, actually we don't have to actually further stress the patient, right? Or perform any other comprehensive imaging, but you need to again look at the score too, which is important so that you can optimize because it's an elective surgery. So even if he has a low risk for cardiovascular event, but because of the cardiovascular risk factors that are not optimized, yeah, that will be the confounding reason why the patient will actually eventually have complications. So these patients above 65 years old with established cardiovascular disease, low risk. So we thought, okay, we have counseled him, but we need to address his smoking issues and we optimize his medical therapy. Okay, so of course the empagliflozin was increased from 10 to 25. He has dual antiplatelet therapy. We started on this atorvastatin 40, and then we added azitrol and fenofibrate, right? Bisoprolol, as well as some anti-anginals. Okay, so the recommendation, again from beginning, all these patients, you will need a clear history and clinical examination, class 1C. It is recommended to perform a pre-operative risk assessment, right? So it's correct for them to refer, okay? And if time allows, I just wanted to show, if time allows, it is recommended to optimize, yeah, guideline recommended treatment again for cardiovascular disease and cardiovascular risk factors before the surgery is 1C. Yeah. So in terms of lifestyle, they also mention here again, smoking cessation 4 weeks before the surgery, which is good because actually the mortality, if they go into depth, for those patients who are smoking and going for the surgery, definitely the 30-day mortality risk is increased, and the complications as well. So what about antiplatelet therapy? So he's on dual antiplatelet therapy, a good 6 months for our drug-eluting stents. We have the second generation drug-eluting stents that previously will require long-term antiplatelet therapy for 1 year. But now we actually have the the drug-eluting stents that you can actually use the antiplatelet therapy for 1 month, 3 months, 6 months. Yeah, so we can actually choose. And in terms of this patient, we can identify his bleeding risk. So he's going for a surgery which has minor bleeding risk, glaucoma, cataract surgery, low risk of bleeding. So after 6 months of usage of dual antiplatelet therapy, you can see here clopidogrel that he's on and aspirin. duration of action. How long do we have to stop? I'm sure a lot of you ask this question and get a lot of referrals. Thank you very much. But it's also good for you all to know, right? Aspirin, we can stop 7 days prior to the surgery. Clopidogrel, as well as Brilinta, ticagrelol, at least 5 days prior to surgery. And when do we start back? Once post-operatively, hemostasis is secured, right? You can start within that 24 hours or the next day, yeah? So shouldn't be a problem for him. We told him he can proceed for his cataract surgery. So how about patients that are high bleeding risk? So another surgery for the eye, vitreoretinal eye surgery, we also get some referral for this. Yes, patients are on is high bleeding risk. So aspirin, you have again to emphasize at least 7 days. So as you can see, this patient, since 48 years old, he has been smoking, with history of diabetes, hypertension, dyslipidemia, 48. So it's a long journey for them, right? So as their aging comes up with all of this cataract surgery, hearing issues, sometimes knee surgeries that they have to go through, which will be my next case, So it's very important to control all of these risk factors, because years after years after years, again, they will come back for some sort of surgery in the future, all because of the, what you call that, the risk modifying enhancement is not really optimized, or patients non-compliance, the understanding from the patient and awareness. I'll move on to my next case. This is the intermediate risk for non-cardiac surgeries. So case 2, Madam Kalsum, right? Very nice, cheerful lady. She was referred for a planned right hip total replacement surgery, the general anesthesia. So she's 66 years old, highlighted again above 65. Sterility score not too bad, 3, still independent, ambulant. The cardiovascular risk factor, diabetes, hypertension, dyslipidemia, and obese. Obese because of this right hip osteoarthritis that she's having, lack of exercise, sedentary. Also, the HbA1c is poorly controlled, 9.6, LDL is 3.2, HDL 1.2, total cholesterol 5.6, PGFR is 58, BMI is high. So very small dose of the atorvastatin. She does not have a cardiovascular event prior to this. Perindopril 8 milligrams, Janumet, and dapagliflozin. So during the pre-op assessment by our NS colleague, patient informed occasional chest discomfort on exertion, NIHA 2. Her blood pressure was all right. Heart rate is about 88. So from orthopedic, went to medical, and then went to the NS team and was referred to us. So again, what we quickly analyze this patient and assess her in the clinic, her revised cardiac risk index, elevated risk of surgery, this is for high risk, so she's intermediate risk, history of cardiovascular event, no, congestive heart failure, again, no, cerebrovascular accident, no, insulin therapy, also no, creatinine also was all right. So actually you see she scores 0, and her 30-day mortality, myocardial infarction risk, as cardiac arrest is only 3.9. But somehow, of course, I know if I do the score up, it's quite high. The surgical risk, 1 to 5%. She's going for a major hip surgery. So we want her to at least reduce her risk and complications. And of course, she's a very anxious lady. Her family is all very supportive. So what we can actually do again to see how we can clear her for the surgery. So the same chart, she, despite her being, above 65, without the established cardiovascular artery disease, so she's in the intermediate risk for of the non-cardiac surgery. So we proceed for ECG, biomarkers is a class 1 indication, and functional capacity again, which you can do. This is another diagram that is quite nice to see. Why I star it like that, because again, versus the patient related risk, moderate risk, and the surgical related risk, also moderate risk. If we can do that, we can see, oh, this one Kalsum needs a increased attention, all right, for her assessment. So you can see here, ECG, nothing very significant. The inversion is indeed 3, cardiomegaly on an X-ray, troponin was 11 negative, pro-BNP also is low. But we know her cardiovascular risk factors, her diabetes, her cholesterol control, yeah, and is very poor, and her obesity again, yeah. So her revised cardiac risk index was 0, I mentioned. She's got a good ejection fraction, 55%. Yeah, you can see here, nicely contracting. So in patients scheduled for elective non-cardiac surgery, she has chest pain or any other symptoms suggestive of undetected cardiovascular artery disease, we need to further diagnostic work, do a diagnostic workup before she goes through the surgery, class 1C. If the patient is in need of an acute surgery, has chest pain and all that, at the same time, so this is, they are trying to tell you elective versus urgent, then of course, this is multidisciplinary assessment at that point of time, yeah. So she's 66 years old. We saw that her echo was normal, but because of a high score 2 risk, we decided, oh, definitely we need to look at her coronaries. So we choose the non-invasive approach for her, right? So we did a multi-slice CT computed tomography of the coronaries, and it showed normal epicardial arteries. Yeah, so this is a little bit of the studies and literature that that they did, that it is recommended as an initial test for diagnosing coronary artery disease in stable patients, yeah, with the low likelihood or no previous diagnosis of coronary artery disease. It's an alternative to your invasive angiogram, right? Excluding if patients are not, non-STEMI lah, isn't it? Yeah. So this is also can be used if your TROPs are negative, your ECG is normal, yeah, and however, bear in mind the practicality of the CT scan does reduce weightage when the patient is actually elderly, almost 70, and when the calcium score is high. Yeah, so good for her that her CT scan was normal. But again, despite all that, goes back to basic. We need to optimize her cardiovascular risk. So high intensity statin, if you remember, she's on Lipitor 20. So we put her on 40 and Azitrol 10. Low dose of bisoprolol was started. Okay, for her weight, we have, we're quite lucky to have GLP-1 antagonist oral. So we started her on that for a little bit of the weight management in our obesity clinic, in cardiovascular risk reduction clinic that we have. We stop her DPP-4. We start small dose of Ryzodeg, yeah, 8 units once a day. Yeah, we want to aim for the HbA1c of less than 7.5. When I read through this, it was quite interesting because in the same paper, the ESC guideline 2022, for patients with diabetic, yeah, pre-operative HbA1c, all right, those who are not performed, you have to actually do it in the past 3 months prior to going for the surgery. Make sure that you see, in case of patients with HbA1c of above 8.5, yeah, actually they state here, class 1B, whether or not you should be postponed the surgery if safe and practical. So it's very important, again, aiming to optimize the cardiovascular risk. So we have counseled her, and she was agreeable for all these medications, and hopefully she can go through the surgery, yeah, with a very low risk, hopefully, yeah, if she is she's able to change her dietary, be compliant to the medication, yeah, and she eventually went for the surgery. The next patient, Mr. Kong, YL, he is planned for lap cholecystectomy. So he's 70-year-old. So 70-year-old, something extra that we need to think about is they are in the geriatric group. So their frailty score tend to be higher. Yeah, so they have mentioned for patients who are frail, it's also something that we need to calculate. So he has CV risk, diabetes, hypertension, and dyslipidemia, chronic kidney disease. AGFR is 36. Recently, unstable angina in May 2024. Troponins was negative. Functional capacity, as you can see there, is a bit frail. So his MET score just nice, 4. Frailty score, he needs some assistance, yeah, with his routine activities. Yeah, but it's very unfortunate. He was admitted a month ago, abdominal pain, yeah, fever. So they've done an ultrasound, and he was hemodynamics, I think he was not compromised at the time, but I think they've counseled him if he's suitable, they are actually offering to do a laparoscopic cholecystectomy. So for Mr. Kong, again, your cardiac risk index, lab chole, intermediate risk, his frailty score, so I put it as yes. Ischemic heart disease, yes, it's unstable angina, current chest pain, quite recent, no congestive heart failure, no stroke, no insulin, and creatinine is it's actually less than 176, so his score is 2, he's at risk at 10.1%. So surgical risk for cholecystectomy, intermediate risk 1 to 5%. For him, it was whether or not he's 70 years old, right? ECGs don't actually later. So in this, we actually decided for a nuclear stress test. So stress test is recommended before high risk, mostly for high risk elective non-cardiac surgery patients with poor functional capacity and high likelihood of coronary artery disease. Class 1B, you can consider for high-risk patients, but they are asymptomatic but poor functional capacity, previously had angioplasty or bypass 2A. Yeah? For this patient, intermediate risk, when ischemia is a concern for this patient because he has a poor functional capacity, his maths was only 4, but it's not routinely done, yeah, for patients that are asymptomatic or low risk, class 3. So ECG, sinus rhythm, no ST changes, cardiomegaly slightly, but he also has a very good ejection fraction. It's about 60%. Yeah, both in the, you can see here, quite nice. But you can see there is some intravascular, the diameter here, ventricular septum and hypertrophy is there. He's 70 years old, long-standing hypertension, but it's a concentric rather than an eccentric hypertrophy. So non-invasive imaging, the nuclear stress test, nicely pointed out by Dr. Faiz, all right? So everything is lighted orange here. There is no reduce in the uptake. Yeah? So you can see here in your apical views, both in stress and rest, your lateral views and anterior and inferior view also, everything looks good here. So it was very, very lucky of him that he has a normal myocardial perfusion imaging study. Despite him being 70, the cardiovascular risk, frailty was that. This laparoscopic cholecystectomy is quite important for him. So we eventually cleared him, and we've given the feedback to the surgical department, and I think he will be going through it. Yeah. The next case would be my high-risk non-cardiac surgery case. It's very unfortunate for this madam. Case 4, Madam Ranjit. She's planned for total abdominal hysterectomy with bilateral salpingo-oophorectomy. It's an intra-abdominal surgery. She's only 60 years old. Known case of cardiovascular artery disease, had an angioplasty done to the left anterior descending in 2001, 20 years ago, 40 years old. She has hypertension, atrial fibrillation, and hyperlipidemia. So pre-op assessment again at this point of time, recurrent angina, not very sure, and then started to have dyspnea on exertion. They did a troponin before sending over. 12 pro-BNP slightly elevated because of the atrial fibrillation, possibly. But one admission recently, 2 months ago, for decompensation, heart failure. Functional capacity is 3. Her score is 3 and percentage is 50. Her Hess-Black score is about 3. Why I calculated the Hess-Black is because she actually has a fibroid. She's been having heavy menses. She's also postmenopausal, all right? Elevated risk of surgery, yes. History of ischemic heart disease, also yes. Congestive heart disease, also yes. Stroke, insulin treatment for diabetic and creatinine clearance is good, so no. But she scored 3. The percentage for 30-day risk of mortality, myocardial infarction, and the rest is 15%. It's quite high here. Yeah. So this is an ECG, as you can see, atrial fibrillation. Yeah. And this is her chest X-ray, cardiomegaly. In her case, she had a previous angioplasty to the left anterior descending. Troponin was negative. Yeah. So we thought we will offer her a non-invasive imaging. You can see here, earlier, all you saw was orange, right? The color, the uptake was good. But here there's some defect, yeah, in the apical lateral region. The mid inferior, basal inferior, lateral and basal inferior area, the uptake is reduced. Yeah, so this depicts that she has moderate area of stress-induced ischemia in the circumflex area. This apparently, distal left anterior descending and right coronary artery area. So that's why for her, we thought, yes, moderate stress-induced ischemia, the patient will require an angiogram. So this is an angiogram. You can see there, left main in this view, this is your spider view, mild distally, and you can see here for the circumflex artery, severe disease ostial, from the ostial goes down and then suddenly complete total occlusion. Yeah, obtuse marginal also severe disease. And here in your left anterior descending, severe disease, you see the stent at this area, there is an in-stent stenosis, very tight lesion. Okay, and this is your diagonal branch from the left anterior descending from the top. If you also very, very tight from the ostial. Right side, it's quite diffuse all the way from the mid to the distal. And then you have two branches that's given out by the coronary artery distally, two branches, RPDA, posterior descending and posterior lateral, but also very severe disease, yeah, especially here in cranial view. So very unfortunate for her now that she has a 3-vessel disease, including the left main, right, and also the severe in-stent stenosis. The ejection fraction is 46%. We started her on guided directed medical therapy for her heart failure. We referred for bypass surgery. It will be a first option for her. And we managed to secure an early aid. So what about her TEPSO? So of course, for her, she is in the high risk for cardiovascular event and she's going for high risk surgery. So we had a multidisciplinary approach and a meeting whether or not there is a possibility of myomectomy. So sometimes this patient, whether or not this AF should be addressed, yes, currently she's on rate control, but however, she's still in AF. So something to think about. Of course, hemodynamically instability, the ESC guidelines have mentioned that she will require cardioversion. Whether or not this patient, but she has a good, still the EF is above 35%, yeah, but bear in mind, we have to anticipate and think whether eventually she will need intra-aortic balloon support during her bypass surgery. Yeah, so that's under the mechanical circulatory support. Yeah, these are all ideas. So the recommendations for timing for non-cardiac surgery and revascularization, patients that need revascularization for their coronary artery disease. So if this patient has an in-stent restenosis of the left anterior descending, right, 20 years after the stenting, but her right side and her left circumflex is normal, just say, right? So yes, if we intervene with angioplasty, or if there was no stent previously, only single vessel disease, if we are going to do angioplasty, it is recommended for this sort of patients to go through, to be stented, or using the drug-eluting balloon. The new generation is recommended over the best metal stent. It's a class 1A indication, right? So with patients, pre-operatively for patients who are indicated for PCI, definitely here, again, we need to refer, that's what it's trying to say, and whether or not we want to do further testing for this high-risk patient can be considered, but depending on, they said, if this patient, what's most important is your left main and your left anterior descending artery. All right. So with patients with acute coronary syndrome, right, these patients, whether or not it can be safely postponed, as it's recommended usually because of the dual antiplatelet therapy that we are going to use. Again, at least 3 months. It's a class 1A indication. So what about patients with the heart failure? It's 1B, class 1B for patients who are going through high risk non-cardiac surgery. Recommended again to evaluate their LV function and the measurement of the pro-BNP. It's good that this hospital actually did all that, right? And for patients who are going through the surgery, again, it is recommended for optimal medical therapy. Okay. Last but not least, one case that I want to discuss, I think this one I actually put it up last minute. It's Muhammad Yusuf. Actually, it's a call. I just got a call during my on-call. I did not get a formal referral, but this patient actually is 57 years old, hypertension, diabetes, atrial fibrillation on oral anticoagulation therapy. Already, patient of ours in IJN, non-ischemic dilated cardiomyopathy, ejection fraction is 35%. So very unfortunate, this young man admitted to the Banting Hospital for fever and headache, neurological assessment, neck stiffness and delirium. So it's actually one of my friends. So actually wanted to perform lumbar puncture for him. So how in this patient, do they transfer over? Do they need a pre-op assessment for this kind of patient? Definitely the patient will need the lumbar puncture, need to measure the pressure, to start antibiotics. So he did a full blood picture. The platelet count was 230, INR is 1.2, eGFR is good, SBAT score is 2. So he was concerned about the oral anticoagulation therapy. So the patient was on dabigatran. As you can see here, the choices of OACs, episaban, dabigatran, endosaban, and rivaroxaban. And this is warfarin. You can see the plasma half-life for warfarin is 36 hours to 48 hours, 2 days. For the OAC, mostly about 12 hours. Shortest would be rivaroxaban and endosaban. So whether or not we should stop for this patient, and when do we need to stop? So the duration of action after the last dose, warfarin still 5 days, and for the OAC, 24 hours. So stopping or reinitiating of for the oral anticoagulation therapy in elective patients. This is elective, but this patient is actually wanting to go to perform a lumbar puncture with a normal renal function, right? So you can see here are the days, whether or not this patient has a minor bleeding risk, low bleeding risk, or a high bleeding risk. Okay, so if low bleeding risk, we can actually stop the medication, the last dose, 1 day before, don't need any bridging, and you can start after. So for this patient, the last dose was the day before, so he's able to perform the lumbar puncture. For high bleeding risk patient, good to stop the patient 48 hours before and restart after 48 or 36 hours later. So you see, for very, very high surgery, 48 to 72 hours later, yeah, to restart. What about patients with renal impairment? So for patients with renal impairment, here is the renal function. So above 80 for dabigatran, 24 hours. For the low risk patients, for the high bleeding risk patients, 48 hours. And for the rest of the OAC, for high bleeding risk, again, 2 days, but the low bleeding risk, 24 hours. But we follow the renal function here. As you go by, mostly dabigatran is renally excreted, right? So that's why it requires for the high, as you can see, the difference between the high bleeding risk, all of the other OAC is about 48 hours, but for dabigatran specifically, renal 80% is cleared by the renal. So if the renal function is lower, you need to withhold extra 3 to 4 days. Okay. So with that, I thank you. I hope I had actually covered quite a big topic, but it was very interesting to dive through it. So I hope at least this will give you some prospects that how you can actually summarize your patients, go through with them, and which are the cases that you need to refer and plan the surgery, ensuring that they have a lower risk of complication than after. Thank you very much.
Okay, thank you very much, Dr. Sharmila Shanmugam, for the very, very, what we call this, comprehensive talk. So now from the two talks that we just heard, let me summarize that actually for the cardiac assessment, we have a lot of what we call this cardiac risk stratification that we can do. And then most of us actually, sometimes we use Framingham, sometimes we use ASCVD, sometimes we use score 2 or score 2 op. So based on what we call this, the guideline that you want to use, none of it say that actually is wrong. Some people use this kind of methods based on their preference, and some you have to remember that no, sometimes we have a patient with a chest pain, some or the technetium scan, some or the CT scan. As long as what we call this is justifiable, so and it give you the correct information that you want, so it will be a good test. Okay. So just like just to recap that Dr. Faiz said that actually remember that our MPI scan is way better detecting ischemia before the ECG happen, even for echo. And then of course there's other indication for the imaging. If you see that if you have a thick wall cardiomyopathy, so you need to do a pyrophosphate scan just to know whether the patient have a cardiac amyloidosis. And sometimes you have a dilated cardiomyopathy. So you want to assess for cardiomyopathy study, which usually the MRI is the best methods to know what is the cause of the cardiomyopathy. And then some actually you just want to know this diastolic dysfunction. Example, you have a patient with a heart failure, preserved ejection fraction. You just want to know whether the patient to confirm your diagnosis for diastolic dysfunction, then you can do the specific test only for diastolic study only. That one we can do it in IJN just to confirm. Sometimes those who are obese, the NT-proBNP can be normal. So that's why it makes it a bit difficult for you to actually know whether the patient have a heart failure, preserved ejection fraction or not. Okay, so like for Dr. Sharmila, actually highlight a very good important points that about the A1C control. That one is very important. There's a study has been done. It's either A1C is not well controlled or your cholesterol is high. You should actually optimize it before the coronary angiogram. Why? Because the study shows that after you do the angioplasty, you can have this no reflow phenomenon. Those no reflow phenomenon means that actually when you open the lesion with a balloon, and then suddenly the flow becomes slow. So actually it's quite dangerous. It's quite dangerous, and sometimes patient can have cardiac arrest during that period of time because increase the ischemia time. Okay, and of course this we want to make sure that all the assessment that we do that is justifiable for the coronary angiogram, because as Faiz said, it's not angiogram doesn't comes with no risk. There's always a risk. Sometimes we didn't notice that patient have left ventricular clot. When you put a catheter, then suddenly the catheter go to the left ventricle and then disrupt the clot, patient can have stroke. So everything comes with the risk. Sometimes we dissect the vessel because the vessel are too fragile, and then later the block because the dissection make the vessel become small, the lumen becomes small, and become difficult to stand or improve the circulation back. Okay, now we go to the questions. Okay, this one I'd like to start with Faiz. Assalamualaikum, doctor. I would like to ask question to Dr. Faiz. When is the suitable time to do heart screening? Got any cut-off point, certain ages, or we have to wait for symptoms or strong family history of CVD? The question number 2 is, as we know that in our country, we have limited resources such as PET-CT. How about costing to do such scan? Some patients have life insurance and etc. Okay, Faiz?
All right. Thank you very much, Dr. Iskandar. So for the first question, suitable time for heart screening, actually it's not really stated in any of the guidelines. But if once you reach adult age, in which mean adult age is 18 years and above, it is recommended for you to start to have your medical checkup. So the next question would be how frequent. All right. So for adults, all right, for adults, if let's say your first medical checkup turned out to be normal, you can do that probably every 2 to 3 years. Okay, that's just a general guideline recommendation. Whereas once you reach 40 years of age and above, your medical checkup you can start do it annually, or maybe the latest also 1 or 2 yearly. This we are talking about normal medical checkup. And when is the next? If let's say you have been diagnosed with some things, then your doctor will start to give you earlier appointment, for example, probably 6 months. And if you're talking about any strong family history of cardiovascular and you are really of concern, of course, you can do it earlier lah. If you are less than 40 years old, rather than do it 2 to 3 yearly, if you want to do it every 1 to 2 years, also okay, right? And then for the next question, about PET scan, yes, PET scan is limited, but it's available in IJN. And the costing to do such scan, so PET scan, usually it will cost you about 3,000 to 4,000. That is the cost in IJN. But for other centers, private centers, I'm not really sure. And for SPECT scan, if you're talking about SPECT scan, it's slightly cheaper, about 2,000. But talking about government hospital, I think not much of a government hospital that have this nuclear scan. So far that I know of, but cardiac MRI and CT scan, that one is widely available.
Okay, good answer, Dr. Faiz. So, remember, actually, there's the cutoff point. Actually, there's none cutoff point. The earlier that you do, the better it is, because some people are born with abnormal channelopathies, means that your heart rhythm is abnormal. You didn't know it until it's too late. That's why some people who are went for marathon or exercise really drastic can just collapse. So sometimes we can detect this kind of what we call this electrical abnormalities of the heart, which patient was born with it, and there's a treatment for it. So that's why actually there's no cutoff point, but at least at 18 years old, if you can do, better do. Okay. Okay. Next, a question for Dr. Sharmila. Patient is a 60 years old female with non-known medical illness, noted incidentally on ECG RBBB. She is asymptomatic. Does she need further cardiac assessment if situation 1, she has family history, sudden cardiac death, and situation 2, no family history of cardiac disease? Okay, you unmute yourself first.
Is that good?
Okay.
Yeah, better. Thank you very much for the question. So a 60-year-old, yeah, incidental finding, right bundle branch block, but asymptomatic and no medical history. Yes, it's very good. So basically, yes, right bundle branch block usually is physiological. The ones that we're worried about is the left bundle branch block. But family history of sudden cardiac death shouldn't be taken lightly. I think it's a very well recognized risk. So definitely for this patient, even though she's 60 without any risk, I would still recommend at least an echocardiogram, because a large cohort of our patients actually are asymptomatic. By picking up the echocardiogram, sometimes you can see the intraventricular septum. They could have this eccentric hypertrophy that I'm talking about earlier, that apical hypertrophy, mid-segment hypertrophy. Some of the patients actually have hook'em. Yeah. From there, these patients eventually, when we ask them, that's why it's very much linked to family history. So it's important, as simple as an echocardiogram. I would definitely recommend for that. And from there, if it is suggestive, what we do in IJN is usually we move on to a Holter test. Sometimes patients, when you dig into further, yes, they might have giddiness, sometimes palpitations. Yeah. So simple recording from the ECG, even though it's depicting right bundle branch block, there are further things that we actually will catch on with a Holter test, or we will eventually, if there's evidence of hypertrophy from this young patient, yeah, and it's asymmetrical, then we will move on with a cardiac MRI. So there's a lot of things that actually we will need to exclude: infiltrative disease, yeah, as well as what's common that, I mean, we actually realize amyloidosis, sarcoidosis. We have quite a number of patients actually. They present with very atypical or rare symptoms. Yeah, some patients just come up, no medical history, suddenly having example, carpal tunnel syndrome. Yeah, it's as simple as that, carpal tunnel. Yeah, when we ask further history, yes, sudden death in the family. Yeah, then when we do this echocardiogram, it's something that we pick up. I wouldn't stress the patient immediately, but definitely will warrant an echocardiogram. Yeah.
Thank you, Dr. Sharmila. So sudden cardiac death can be anything, anything as long as the patient died without any reason is considered a sudden cardiac death. And we have a lot. We have a lot of case sudden cardiac death, and of course, when you have that, actually young patient, you need to investigate for the family members also, because sometimes we can actually prevent for the other family members to have the same problem. Okay, next, I go to Dr. Faiz. Okay, during routinely yearly assessment of 70 years old male patient with underlying diabetes, hypertension, dyslipidemia, he has occasional monomorphic PVC. Asymptomatic, does he need further cardiac assessment test done, or echo, or Holter monitoring?
Okay, thank you very much for the question. So yes, looking at the 70-year-old with diabetes, hypertension, and dyslipidemia, at least this patient is at low to moderate risk of CAD event. But then, if talking about PVC, first of all, we need to quantify the PVC burden. Yes, this patient warrant a Holter, but knowing that he is asymptomatic, then we can arrange early appointment Holter. It doesn't mean that this patient needs an inpatient one, right? So we arrange a Holter, quantify the PVC burden, because based on the AAC guidelines, the way you treat PVC is based on the PVC burden. If let's say the PVC burden more than 20% per day, then we can talk about medical therapy versus catheter ablation. If it's in between 10 to 20%, it's a gray area, we can try medical therapy first. If it's less than 10%, either we watch and wait, or if there's a mild symptom, we can start medical therapy. So medical therapy means the medication that we usually start is beta blocker. So, but in certain case, if let's say not responding, we can consider some anti-arrhythmic. So that is talking about the PVC burden. Second thing is that you need to know what's the cause of the PVC. So, so you need an echo. You need to rule out some structural heart problem. If you are thinking about some high CAD event, probably you can do some CTCA or functional scan, and then we go from there. If let's say echo is clear, and then from a CT scan, for example, or any perfusion imaging, everything seems normal, likely we are dealing with some electrical problem. So that is either medical therapy or ablation or watch and wait, right?
So very good answer, Dr. Faiz. So actually, the most important part is you need to quantify the PVC. The management is afterwards. How fast the management is based on the symptoms. Okay, sometimes it's 1 to 10%. If no symptom, we can just still continue medication. But also we need to know what type of PVC is. RVOT PVC, LVOT PVC have different class of intervention with catheter ablation, but it's treatable. So this symptomatic PVC is very important, that we need to do catheter ablation, so that actually the patient won't go to VT, ventricular tachycardia later on. And this, remember, VT, you do CPR also, it won't improve. You need a shock. So that's why actually some kind of, it's either we ablate or actually we have to put in the ICD to prevent further occurrence of this VT episode. So next question will be last question to Dr. Sharmila. Based in experience, the issue when giving feedback for cardiac assessment for surgery is that often the surgeon do not understand the risk score. They often just want cardio to clear this patient cardiovascular-wise. Understandable? Instead of a risk assessment, how do we go about this? Any issue with anesthesia so far? Okay, I meet first.
Okay, right. So, yeah, agreed. Sometimes the referrals that are coming through are mostly from the department, meaning either from the nephrology unit, yeah, from the dental itself. Surgery, yes, but some of the patients, they do refer to the medical, eventually seen by the NS. And then I think that's also very good because the NS also refer us. They will do their perioperative assessment. Sometimes what they pick up is LBBB or a LVH. Yeah, agreed. The surgeons, what they look at is the surgery that the patient need to go through, right? But holistically, I think with a lot of medical background, underlying disease, cardiovascular established risk factors, physicians actually are prompt in this. So definitely they will refer. Surgeons, they need to do what they need to do, emergency versus the elective surgery. Whichever emergency, I think they carry a very high burden, intraoperative and post-op complications. So I think, yes, a bit difficult in the KKM setting where they just refer and expect the physicians or the NS, yeah, to come by. But like I said, we get a lot of elective cases. Like Mr. Kong, he was for laparoscopic, what do you call that, cholecystectomy. The surgeon wrote himself, and because he noted that this patient was elderly, yeah, they would definitely just refer to the cardiovascular cardiac centers if they require. But if, of course, you are patient itself can't able to come, an ECG and the echocardiogram is something for the intermediate and high risk patients that you can do in the local setting. And I think NS can guide if there is no established cardiovascular event, then I suppose, yeah, if, like I mentioned, if there's an acute event or a stable angina that has occurred, unstable angina, then that are the patients that will need to refer. Yeah, I think that will be my answer.
Thank you, Dr. Sharmila. So actually, there's many ways actually you can do this kind of to make other department understand our views. I think one of it that we always done in IGN is to do a Zoom meeting straight away for MDT. So we can do it anytime, any place, and then we don't need to go to other centers, and then we just need a history, and we will provide the what we call this, the cardiac assessment. If other got necessary questions afterwards. I think the most difficult one is always to start what we call this we've got to stop antiplatelet for surgery, especially those who are doing after primary angioplasty, percutaneous coronary intervention. So whether 1 month is enough, 3 months is enough, if stop, what is the ischemic burden? This is a thing that actually we need further. Actually, sometimes Zoom meeting MDT will be better so that you understand. Last time we have what we call this a Zoom meeting regarding a postpartum patient who just delivered and have EF of 10% intubated, overloaded. So of course, in this kind of patient, no, sometimes you give high dose inotrope, all 5 inotrope also, the blood pressure won't pick up. So you for postpartum period, you need time for the heart to contract back normally. So in this kind of case, straight away we do a Zoom meeting. We inform the hospital who referred to us that ECMO is the best for the patient. So that ECMO is extracorporeal membrane oxygenation. It's like a second heart for the patient while waiting for the normal heart to improve. So straight away we take over to our center for further assessment, management, and also ECMO for this patient. And patient survive actually after the ECMO, and then the EF improved to 30%. So actually, this kind of things, if you think it's emergency, we can do MDT. Don't worry. Just refer the case, and then we see how actually we can actually accommodate your request. So we've got another question I give to Faiz lah from the chat box. Actually saya nak tanya kalau patient ada ada history of inferior MI with right sided involvement yang ada underlying OM intra-op MSSA. Oh, osteomyelitis. Okay. Boleh proceed dengan angiogram ataupun tidak?
Okay, so we are talking about MSSA osteomyelitis and history of inferior MI with right-sided involvement. So, okay, history of inferior MI ni either is a miss MI or late presentation MI. So, I mean, there are few in the guidelines. Let's say patient is asymptomatic, there's no rush to do the angiogram, especially talking about MSSA bacteremia, which is a very, I can say, nasty bacteremia, which can go dissemination very bad. So I think everyone also know this. So in this case, if the patient remain asymptomatic, I mean, we can do an assessment with echo and ECG. If there's nothing of urgent, treat the MSSA bacteremia first, because doing angiogram in this case will cause further dissemination and deterioration. And in fact, in certain case, for late presentation MI or miss MI, there's a study, if I'm not mistaken, named OAT trial. There's no role of doing angiogram. So in fact, we just go with medical therapy first.
Yeah, it depends on the agency.
It's actually the MSSA in terms of my ID background, it's actually complicated and uncomplicated. So if we are talking about uncomplicated MSSA, don't have dissemination, only in the bloodstream, right? No dissemination to the bone, the spine. For yours, osteomyelitis will be complicated MSSA bacteremia. So definitely will need intravenous antibiotics, I think 4 to 6 weeks. And then you need some ID clearance. But of course, in terms of the sepsis, and you definitely will need to clear the MSSA prior to performing angioplasty. So far, it is quite rare, but however, risk of infective endocarditis and all that will be a concern, isn't it? Yeah. So medical therapy to support, and once the infection is clear, then refer, then eventually we will do angioplasty. Yeah, just to add.
Good. Okay lah, we do another question lah. I think we still got time, 6 minutes more. Okay, Sharmila. So, doctor, patient successfully thrombolized with methylase. Yeah. Within a month, patient admitted to ward complaining of chest pain. Admitted to completed for 5 days. Treat as non-STEMI. So post MI got non-STEMI. After that, and again within 3 weeks for Astrobojana. So what is the question now? Maybe we need to wait for the question. I think what is the next? My question is still
okay. It's coming.
It's coming. Okay, it's coming question. Okay.
It's all right. It's a good question.
Okay. Okay. So the question is whether we need to wait for the angiogram or how. Okay. I think okay, kalau I give this one Dr. Sharmila to give elaborate the answer for us.
So myocardial infarction at that point of time, yes, agreed. So the studies actually show post MI, recurrent ischemic event will happen, isn't it? Yeah, within that 30 days, mortality is high. So by right, if possible, to refer the patient post thrombolysis day 3, day 4, day 5. For IJN, yes, we are more in terms of we want to approach the patient earlier if all the complications are not there in terms of sepsis, infection, and all of that, isn't it? But most of the patient thrombolized or late presentation can be referred inpatient. We are happy to take over. For those patients, sometimes, yes, want to go home and don't want to come transfer as inpatient. As you can see here, very clearly it shows non-STEMI after 5 days, after few days, isn't it? After a month. We know already by the guidelines, definitely they will come back. That's why we want to do as soon as possible. For us, even if we give an outpatient referral, within 1 week, we want to see the patient and we will immediately post the patient the following week or the next day, no problem. Yeah. So time is myocardial. So this patient has not been revascularized, epicardial arteries, microvascular dysfunction. The later the ejection fraction will drop. So this patient again came in for unstable angina. It's just not enough for medical therapy. So it's very strictly to inform you guys, high risk myocardial infarction and high risk non-STEMI prioritize, hopefully for inpatient transfer if they're stable. The other non-STEMIs, yes, within that 1 month, hopefully we can get the, we will definitely do it very quickly for revascularization, but the referrals need to come early. Yeah, Dr. Faiz, if you want to add.
Unmute.
Yeah, sorry. What's your take? Let's say patient still on IV antibiotics and then still having this recurrent ACS. Do we still go for angiogram? Do we?
Sorry. You have to ask from the beginning. We
Oh,
only
okay.
hear
Is this the same
up.
patient for the MSSA? I don't think so, right?
Or okay.
Actually, for this kind of questions, actually it's quite interesting because why? Yes, what Dr. Shamda said is correct. Why? Because we need as early as possible the angiogram so that we can address the stenosis of the coronary. If you have to remember that when you do what we call this methylase or thrombolysis, you only reduce the 10% or maybe 10-20% of the coronary stenosis by the blood clot. Okay, but you have to understand how the atherosclerotic progression. So it's already have maybe 90% block. Because of the 90% block, now there's a coronary blood flow stenosis, making the blood flow become stasis. So when it becomes stasis, it become blood clot. So when it become blood clot, then it will stop. It will actually reduce the blood flow. And sometimes the rupture thrombus from there also actually can block the distal circulation. So thrombolysis, yes, can reduce by 10%, but you are not addressing the block. That's the problem. So that's why patient can come again, recurrent ACS afterwards. So actually, honestly, in Malaysia, we have this ACS registry. It shows that those of having non-STEMI have the higher mortality rate compared to STEMI. Because why? Non-STEMI, usually you give Fonda and then you discharge and then you give appointment for cardiology afterwards. But for the STEMI one, you can call straight away for most of the center that nearby the cardiology center, you can do primary angiogram. That's why their outcome, even though their severity is higher, but they get the proper treatment first. But this non-STEMI, they get it a bit later. But still, we know actually this non-STEMI can be 2 vessel disease, 3 vessel disease, or left main stem involvement, which anytime actually can have another acute coronary syndrome. So that's why actually we, if possible, we need to do it early. That's the aim. And understand some center actually is quite difficult because the work burden is very high burden. So that's why sometimes patient need to queue also in between. And but to do in private is very expensive. That's another thing that you need to understand. If you can use your insurance, you can do it faster. Okay, so I think okay lah. Last question, Sharmila. May I know there is a need to withhold
I can see.
aspirin or
Because
warfarin
I
prior
think
to
this is the
enter?
MSSA patient. Okay.
No.
Even patient, this one, so doctor, even patient got MSSA, still we can proceed. Oh, okay. So if the MSSA, unfortunately, you can have a septic myocardium. So the bacteremia is there, but no halangan. There is no halangan untuk tak buat angio. Cannot. This patient is the MSSA patient.
Yeah,
And that's why having recurrent chest pain while that infection is there.
So
Worst come to worst, either diagnostic, isn't it? Yeah. how septic are all the septic parameters depending? Is the septic parameters actually responding? Is this patient actually responding to the antibiotic regime, infectious disease referral? Yeah, this is the osteomyelitis case, Dr. Iskandar.
Yeah, if very septic, sometimes it's a type 2 MI. So because of other problems, so that's why you need to treat this one, what we call this the infection first. But of course, we have other modalities. CT scan also can be done without putting a catheter on the hand. Everything. So actually, there's a lot of modalities. But in these kind of things, you see, never mind. If you have this kind of case, just refer to the cardiology on call. We're going to give our views and then see actually what is the best for the patient. Okay.
Yeah. Eventually, again, it will be multidisciplinary. We have infectious disease coming on board.
Yes.
We will share the case. We will discuss heart team approach. What is best, the risk and the outcome, and what are the complications that can arise. So we will actually overweigh the risk and benefit for the angiogram and angioplasty if required at that point of time, or we can wait, treat with the antibiotics. There's no right and wrong answer here. Sepsis is more than it meets the eye sometimes, yeah. And MSSC is definitely something that is not to be taken lightly. And this guy with the osteomyelitis, yeah. So, but at the same time, the heart as cardiologists, of course, we want to do what is best, yeah. But yes, if this becomes a complex case, then we will call for the multidisciplinary approach, yeah.
So I think we reached the end of our session tonight. Such a very good lecture by both of the speaker, Dr. Sharmila and Dr. Faiz, and such a good actually questions from the audience. It's all practical question. I understand all these questions I asked actually is what we have in our daily practice. The referral that we have is the same. The question that you give. So actually, there's a question whether you guys can share your slides. If both of the speaker agree, maybe you can just type in your email in the chat box here, so that actually the participant can email you whether they can share, you can share your slides, and then I think that's it. So thank you very much, Dr. Shanmugam and Dr. Faiz. And remember, guys, don't forget to actually click on the Google form for MSCD point. You will get 2 points for the what we call this for the CPD point. And then hope to see you next time. So we always do this every 2 weekly, and then the next one will be posted in our MedTweetMY social media. With that, thank you very much. Okay, bye.
Thank you very much, everyone.